Hi everybody, this is the second episode of our podcast and we are going to talk about a new type of bone tumor, the blue tumor. It's a 62 years old female who complained of hip pain for 1 year. The X-ray of the right hip showed an intramedullary osteolytic lesion in the trochanteric region with ill-defined margins, destroying the cortical bone with a periosteal reaction and a large extension to soft tissues. This lesion contains calcifications, which are characteristic of cartilaginous matrix. So, it's an aggressive lesion with cartilaginous matrix metaphyseal in the proximal femur of a 62 years old female. This lesion is more likely to be a chondrosarcoma. The CT scan confirmed the cartilaginous matrix of the lesion, destruction of the cortical bone, and the large extension to soft tissues. 2 points are important to mention: the absence of articular extension and the safety of the vascular bundles. MRI remains the best mean to assess local extension of a bone tumor within the medullary canal and to soft tissues. From a surgical point of view, the assessment of articular and neurovascular involvement are paramount. MRI is mandatory for the pre-op planning. The weakness of MRI in cartilaginous tumors is the visualization of calcifications. On histology, the tumor showed a cell proliferation in an abundant, remarkable blue background. The blue color is characteristic of chondroid matrix. The tumor is hypercellular. The malignancy is undoubtful. We are facing a chondrosarcoma. The figure on the left shows some atypia and binucleated cells. Mitosis are uncommon in chondrosarcoma. On the right, we can see clearly that this tumor has a permeative growth pattern, which is an important feature for the diagnosis of malignancy in cartilaginous tumors. Grading of chondrosarcoma is essential for the prognosis. The first figure on the left is a chondroma, which is the benign counterpart of chondrosarcoma. The second picture is a grade 1 chondrosarcoma, which is a little bit more cellular than a chondroma. The differentiation between a chondroma and grade 1 chondrosarcoma is one of the most challenging tasks in musculoskeletal pathology. In the next picture, the cellularity is more important, and this is a grade 2 chondrosarcoma. This is our tumor. Grade 3 chondrosarcoma are characterized by more pleomorphic nuclei and much more cellularity. The tumor can even lose its chondroid matrix, which become more myxoid, as we see in this case. Grade 1 chondrosarcoma is the low-grade tumor. However, grade 2 and grade 3 are the high-grade tumors. Chest CT didn't show any metastasis, and according to the Enking staging system, this is a high-grade extracompartmental tumor, so it's stage 2B. Treatment of chondrosarcoma is almost exclusively based on surgery. Mitosis are rare, and the growth of the tumor is related to matrix production, so antimitotic agents aren't efficient. Chemotherapy and radiation therapy have a very limited role in the management of chondrosarcoma. The aim of surgery is to achieve wide margins, which is an important prognosis factor. In this case, limb salvage is recommended since the resection of the tumor with wide margins is possible. We performed a resection of the tumor through a lateral approach and reconstruction with a megaprothesis. A technical detail: it's advisable to use a bipolar cap when we reconstruct the proximal femur with a megaprothesis. Post-operatively, we use a brace for 3 months to avoid hip dislocation. On the macro section, we can see that our margins were wide. We can see a bluish tumor invading the medullary canal of the proximal femur. Cartilaginous tumors are typically lobulated, and there is no sharp boundaries between the tumor and the cancellous bone, and this is what we call permeation. Permeation is the capability of a tumor to invade and to penetrate the host bone. As depicted on the right, we can see numerous cartilaginous lobules surrounding the trabecular bone and destroying it. This is an important feature for the diagnosis of malignancy in cartilaginous tumors. One of the most important prognostic factors in chondrosarcoma is the surgical margins. This figure shows the results of our series of chondrosarcoma treated in Kassab's Institute, and we see clearly that the survival rate between adequate and inadequate margins is statistically different. The second most important prognostic factor is grade of malignancy. The higher the grade, the more aggressive the tumor is. The figure on the right shows that grade 1 chondrosarcoma has significantly better prognosis than high-grade tumors. One last thing that I'd like to mention while talking about chondrosarcoma is the differentiation. The differentiation happens when a cluster of tumor cells loses its cartilaginous differentiation and develops a new phenotype totally different, as if your big cat becomes a monster. In the figure of the right, we see cartilaginous tumor intermingled with spindle cells. This subtype has the worst prognosis with a 5-year survival rate less than 10%. In summary, we can say that chondrosarcoma is primitive malignant bone tumor with chondroid differentiation. It occurs in the adults. Its treatment is surgery and nothing else, except in some rare subtypes. The two main prognostic factors are grade of malignancy and surgical margins. Finally, I would like to present all my acknowledgement to my colleagues from our MDT, and especially the pathologists and the radiologists who provided us with these nice figures. Thank you.